So welcome to this webinar on capnography, and I've titled the webinar Capnography and Why It Is the Anaesthetist's Best Friend, and I'm hoping to convince you that actually capnography and capnography units are one of the most informative pieces of anaesthetic monitoring equipment that we have at our fingertips and can use if we know how to use it and understand what we're looking at. So this is just a bit of an outline of what I'm going to talk to you about in this webinar. So I'm going to start about basic physiology with particular relevance to capnography, so focusing primarily on the respiratory system. And this is because with any piece of monitoring equipment, I really believe that a knowledge of the underlying physiology is really important in order for us to understand what the monitoring equipment is actually telling us, and therefore for us to be able to use it to its maximal potential. We're then going to move on to the many possible uses of capnography, including what it can tell us with regards to our patients and also the equipment that we're using. Additionally, we're in a time when people are focusing on how veterinary professionals can conserve oxygen and inhalational agents. This can be for a multitude of reasons, including for a sustainability and environmental impact, for economic benefits, and also for potential availability issues. Therefore, we're going to briefly touch on why use of a capnograph can be beneficial in this situation. Finally, we'll discuss how we can interpret our capnograms and also make the most of them, and I'm going to go through a number of different common examples. So starting off with the physiology, the primary function of the respiratory system is obviously the exchange of oxygen and carbon dioxide between the body and the environment. The respiratory system also has a number of secondary functions, including being a vascular reserve, being a filter for blood and airborne substances. It plays a role in immune defenses and also has some endocrine and metabolic functions. But we're not going to cover any of those secondary functions today. We're just going to focus on its primary role in terms of exchanging oxygen and carbon dioxide. If the respiratory system is not functioning optimally, because of its role in oxygen and carbon dioxide exchange, the patient will suffer from a reduced tissue oxygen delivery with resultant hypoxia and also a buildup of carbon dioxide with resultant acidemia. In terms of control of ventilation, the major physiological driving force for ventilation is a patient's arterial levels of carbon dioxide, not their arterial levels of oxygen. It should therefore come as no great surprise that when we're measuring carbon dioxide levels in a patient's respiratory gases via capnography, we will be gaining some information on the patient's ventilatory status. The main control of a patient's ventilation comes about via central chemoreceptors, as opposed to peripheral chemoreceptors. These central chemoreceptors are highly sensitive to changes in hydrogen ion concentration and therefore are also highly sensitive to partial pressure of carbon dioxide. Although the peripheral chemoreceptors do respond to hydrogen ion concentration, they do so with a reduced sensitivity compared to these central receptors. However, the advantage of the peripheral chemoreceptors is that they do respond much more rapidly, therefore allowing a quicker response to change. With regards to the central chemoreceptors, generally speaking, an increase in our partial pressure of carbon dioxide in the arterial system, our PaCO2, will cause an increase in the patient's alveolar ventilation. Although it's important to note that this effect is lost with extreme hypercapnia, which produces central depression and narcosis and therefore reduces the ventilatory response to carbon dioxide. On the flip side, decreases in our PaCO2 decrease our alveolar ventilation, although again, this effect ceases at less than 30 millimeters of mercury. There are various factors which can influence the sensitivity of chemoreceptors. Of particular importance for the anaesthetist is that an increased work of breathing reduces the response to carbon dioxide. This is particularly relevant for brachycephalic patients who usually have an increased work of breathing due to their anatomical features. This means that the level of PaCO2, which acts as a trigger point for these patients to breathe, will be higher. Therefore, with these patients, we will commonly see hypoventilation under anaesthesia because their set point, their trigger point to breathe is higher anyway. And we will find that these brachycephalic patients often have a higher PaCO2 compared to what is usually considered normal. While hypoxemia has virtually no effect on our central chemoreceptors, it is the peripheral chemoreceptors which are primarily responsible for detecting decreases in PaCO2 and blood flow. As these peripheral chemoreceptors are positioned in the carotid and aortic bodies, they effectively act as oxygen delivery sensors for the brain, which is obviously an organ which is particularly vulnerable to hypoxemia. Supranormal levels of oxygen have virtually no effect on ventilation, but once our PaO2 drops below 60 millimeters of mercury, exponential increases in ventilation occur with further PaO2 decreases. The hypoxic ventilatory drive is particularly important for patients with chronic lung disease who suffer with chronic hypercarbia. If these patients compensate for hypercarbia by retaining bicarbonate and therefore producing a normal pH, although it's a relatively rare situation to be in, such patients have their ventilation no longer driven by a high PaCO2, so a high carbon dioxide as normal, but it's driven rather with a low PaO2. Oxygen supplementation in these rare cases of chronic lung disease can therefore suppress their ventilatory drive. So in these situations, although clinically the patient may need oxygen administration, caution is advised because we may reduce their drive to breathe. Although this talk focuses on capnography, it is important to remember that basic hands-on monitoring gives valuable information. Occasionally, anaesthetic monitoring equipment will give artifactual information, and the basic monitoring is critical to distinguish this from what is really happening. In terms of the respiratory system, there are a number of things that we can do as part of our basic hands-on monitoring. Firstly, we can have a visual assessment of the patient's chest movements, which allows evaluation of the respiratory pattern, effort, and rate. We can perform a manual inflation of the patient's lungs by squeezing the reservoir bag with the APL valve closed, and this allows a crude assessment of the pulmonary compliance and inspiratory resistance. This also gives feedback regarding the presence of upper respiratory tract obstructions, and in the case of anaesthetized patients, that is primarily involving the endotracheal tube. And it can also give us an idea of whether there's any pleural space disease. Finally, we can perform thoracic auscultation, which allows identification and location of abnormal lung sounds indicating potentially developing problems, including pulmonary edema or aspiration, which can be detected as crackles, bronchoconstriction, which can be detected as expiratory wheezes, or pleural space disease, which can be detected as muffled lung sounds. However, we're mainly today going to be talking about capnography. Now, capnography is what I call a real-time, it gives us information pretty much straight away. So it's a real-time, non-invasive measurement, and it provides a numerical display of the carbon dioxide concentration in the patient's respiratory gases during normal breathing. It also can measure the patient's respiratory rate. While both inspired and expired carbon dioxide concentrations are measured and both do provide useful information, it is the expired concentration with which we are most interested in. And the peak expired carbon dioxide concentration is referred to as the end-tidal carbon dioxide, or the EtCO2, which we can see on this diagram here. And that's an important number to be aware of, and we'll come back to this quite a lot through the talk. So the peak expired carbon dioxide concentration, or the end-tidal carbon dioxide, is usually displayed with the units of millimeters of mercury. And through the rest of the talk, that's what I'm going to be referring to our end-tidal carbon dioxide in, is millimeters of mercury. But be aware that it can be measured in other units as well, primarily kilopascals or percentage. So some monitors are set up to record in those units. Now, our end-tidal carbon dioxide is interesting because this is taken to represent the alveolar partial pressure of carbon dioxide. So that is the amount of carbon dioxide present within the patient's lungs. And in the healthy patient, this correlates well with the arterial partial pressure of carbon dioxide. And in the healthy patient, we would expect the arterial partial pressure of carbon dioxide to be only about 2 to 5 millimeters of mercury higher than the end-tidal carbon dioxide. And as we've just discussed, it is the PaCO2 which is the main physiological driving force of ventilation. Therefore, capnography is a really easy way to give us a continuous, relatively accurate real-time measure of what is happening with the patient's carbon dioxide levels. And it's certainly much easier than taking repeated blood gas measurements, for example. Carbon dioxide is produced in the body's cells as a result of metabolism, and it is then carried to the lungs by the patient's circulation. It's then removed from the body and from the lungs by alveolar ventilation. So therefore, end-tidal CO2 is determined by these three factors. We have metabolism, circulation, and alveolar ventilation. When two of these three factors are stable, capnometry provides us with information on the third factor. So for example, this is the principle behind using capnography during a CPR session. CPR, we assume that in this short period of time, cellular metabolism is continuing at a similar rate to previously, and that the alveolar ventilation is constant because it's being performed by a member of the veterinary team. Therefore, capnography will be able to give us information on the patient's circulation. That is, how effective our chest compressions are being. It can therefore also fairly reliably tell us when we have return to spontaneous circulation in our patient, because we will see an increase in our end-tidal carbon dioxide of more than 10 millimeters of mercury. And this is because the patient's heart is much more effective at circulation than we can ever be with our chest compressions. So we get this improved end-tidal carbon dioxide with improved venous return and circulation. Capnography can also give us really valuable information regarding our anaesthetic equipment, with examples including whether we have a correctly positioned and patent endotracheal tube, because if we place the endotracheal tube in the patient's esophagus, for example, we should not be getting any carbon dioxide produced, so we will get a flat line on our capnography trace. It can also help us identify whether there are any leaks in the anaesthetic breathing system, whether our fresh gas flow rate is adequate or inadequate if we're using a non-rebreathing anaesthetic system, and we'll come back to this in a little bit more detail later. And if we're using a rebreathing system, such as a circle breathing system, it can tell us whether the carbon dioxide absorber is exhausted, or if we have a malfunction in one of our one-way valves. And it can also give us some information as to whether there is excessive dead space within the anaesthetic breathing system. So we can see from these last couple of slides that actually we can gain a whole host of information from our capnograph, not just about the patient, but our equipment as well. So if it's used in the right manner, we can gain loads and loads of information. A little bit about the different types of capnographs that are available. They can either be known as mainstream analyzers, where the sensor is placed directly between the endotracheal tube and the breathing system, or side stream analyzers. And it's much more common to have a side stream analyzer, and so therefore I'm going to concentrate primarily on this type. So side stream analyzers require a gas sampling line to be attached to a connector near the endotracheal tube. Samples are taken to the anaesthetic monitor from this gas sample line, and water vapor is removed prior to measurement through the use of what's known as a water trap on the side of the anaesthetic monitor. The gas samples are taken away from the endotracheal tube and the breathing system at a rate somewhere between 50 to 200 mils per minute, and that varies from monitor to monitor. Which does mean that there can be a delay from the patient taking a breath and it appearing on the capnogram. A higher sampling rate reduces the response time of the monitor, so you get to see your response a lot quicker with a higher sampling rate. But it does also mean that a larger part of the fresh gas flow is lost each minute, which can become quite important or relevant when we're thinking about using low flow anesthesia, particularly with our rebreathing systems. A useful thing to think about with side stream analyzers is that they can actually be used in conscious sedated patients. And that's because endotracheal intubation is not actually a prerequisite for sampling. Obviously, you get a better sample, a more reliable sample if you are taking your gas sample from the end of an endotracheal tube, but it's not essential. The gas sample line can be placed at the level of the patient's nares, and that can be, for example, attached to an intranasal catheter, or you can use, as you can see in this picture here, a normal intravenous catheter with the stylet removed, attach that to the end of the gas sample line, and put it down inside of a face mask next to non-intubated patients. For people that are interested in this picture, the patient is actually a beaver, which I appreciate is not our normal species that we deal with, but it does illustrate the point that I'm trying to make quite well. Nasal capnography has been shown to provide an acceptable alternative to arterial blood gas analysis in both sedated and conscious critically ill dogs. But we do need to be aware that we need to try and get the gas sample as close as possible to the patient, so as close as possible to the nares, or even better from an intranasal catheter, in order to attempt to measure alveolar gas. So just a little word on how capnography can help us be less wasteful and help us with our drive to be more sustainable as a veterinary profession. Now, it'll come as no great news to you all that on a global scale, greenhouse gas emissions are rising, and it's reported that we're likely going to be burning through the rest of the 1.5 degrees centigrade carbon budget within the next 3 to 10 years, which I'm sure you're aware could lead to some pretty scary potential consequences. From our perspective as veterinary professionals, anaesthetic agents are greenhouse gases, and some of the agents are also ozone depleting. Therefore, we have an obligation to minimise the amount of waste gases that we produce in our daily work. Just as a couple of examples of how significant anaesthetic agents can be in terms of their effect as greenhouse gases, if we look at just one bottle of isoflurane, when used, that produces equivalent emissions as driving from Plymouth to John O'Groats. And the estimated annual global impact of anaesthetic gases is equivalent to either one coal-powered station or around about 1 million passenger cars. So it is important that we are conscious of what we're doing and make an effort to try and reduce our impact. We can see from this table here that also the different anaesthetic agents have a differing level of impact, with nitrous oxide and desflurane being the worst out of the commonly available anaesthetic agents. In terms of how capnography can help us reduce our waste gases, one example is if we're using non-rebreathing anaesthetic systems. So that includes systems such as our T-piece, our Bain, or our parallel lag. And use of a capnography unit can help us avoid using excessive fresh gas flow rates while ensuring we're maintaining safe rates for our patients. And this will help minimize the amount of waste gases that we're producing. It will also allow us to conserve our resources, so our oxygen and volatile agents, and it can help minimize environmental and economic impacts that we have. So when we're using a non-rebreathing anaesthetic system, it's recommended that the fresh gas flow rates for our patients are calculated in the usual manner, and that is taking the patient's minute volume, which is the product of the tidal volume and the respiratory rate, and multiply that by the circuit factor for the individual system that we're using. However, if we then are using a capnograph in addition, from this calculated flow rate, we can reduce our fresh gas flow to a rate just above a point that a patient starts to rebreathe. And we can see an example of rebreathing in the schematic diagram on this slide. So rebreathing basically means the patient is breathing back in carbon dioxide from their previous exhaled breath, their exhaled gas. So they will have a trace which does not reach baseline, does not reach zero. And we want to avoid this, but with using a capnograph, we can reduce our fresh gas flow rate with our non-rebreathing systems down to the point just above where this occurs. So it allows us to use the minimal safe flow rate for that individual patient. If you're interested in further information on oxygen and volatile agent conservation through, particularly through low flow anesthesia and rebreathing systems, this can be found with previously recorded webinars available from Davies veterinary specialists. In terms of any breathing system, so that's non-rebreathing systems that we've just discussed, and also rebreathing systems such as our circle system, capnography can aid with detecting system leaks during anesthesia. And again, if we can identify system leaks, we're going to help minimize waste gases that we are producing. So while all breathing systems should undergo a leak check before use, it is possible for a system leak to develop during anesthesia. And this is usually arising from an inadequate seal around the endotracheal tube cuff. And if we have capnography, we can often detect this, and this will give us a trace similar to what we see here on this slide, which we'll cover in a little bit more detail in the examples later on. But you can see that you end up with a very different trace. The last two curves on this trace are very different from the normal trace at the start. But as I say, we'll come back to this. So in terms of how we can actually interpret our capnograms, most of the capnography monitors don't just give us a number for our end-tidal carbon dioxide. They also plot a capnogram, which is basically an illustrated version of the changes in our carbon dioxide over time. And as I say, we can gain quite a lot of information by looking at the shape of this capnogram, as well as just looking at the numbers that we can see. The capnogram can be split up into 4 different parts. We have phase 0, starting with phase 1, phase 2, phase 3, and we actually end on phase 0. So phase 1 that we can see highlighted here represents the inspiratory baseline. Now, if we had our graph axes on this picture, we would see that this baseline would be at 0 millimeters of mercury for concentration of carbon dioxide. And this makes sense because when we breathe in, we should not be breathing in any carbon dioxide. So we would expect this to be 0. Phase 2 represents the expiratory upstroke, and this is the beginning of expiration, which again, it makes sense. When we start to breathe out, we would expect there to be carbon dioxide. So we would expect there to be a rise in the level of carbon dioxide which is present. And phase 2 represents the expiration of gases from the conducting airways and the alveoli. And these 2 sets of gases from the conducting airways and alveoli start to mix during this phase, and they generate a steep increase because there is a very rapid rise in the amount of carbon dioxide which is breathed out. Phase 3 is the expiratory or the alveolar plateau, and this represents the exhalation of pure alveolar gas. This phase may be completely level, completely horizontal, or it might have a slight upward stroke, which is often seen because of uneven emptying of the alveoli, because they don't all empty at the same rate. And then the alveolar plateau ends at the highest point, which is the end-tidal carbon dioxide, which, as we've said, is usually the number that we're most interested in. And then finally, we have phase 0, which is the inspiratory downstroke, and that occurs at the start of inspiration. And if we think about what happens when we're breathing, when we start to breathe in, we expect there to be no CO2 in the gas that we're breathing in. So we would expect this nice rapid drop in our capnography trace. In terms of what is normal for our end-tidal carbon dioxide levels, as we've already said, in most healthy dogs and cats, the end-tidal carbon dioxide is very similar to the concentration of carbon dioxide in the patient's arterial blood. And we can define our carbon dioxide concentrations as either hypocapnia, where there is less than 35 millimeters of mercury of carbon dioxide, normocapnia, where there is 35 to 45 millimeters of mercury, or hypercapnia, where there is more than 45 millimeters of mercury. If we're looking at cats, we tend to find that cats have end-tidal carbon dioxide readings which are more towards the lower end of the normal range, but they equally, we still tend to class normal as the figures quoted here. Mild hypocapnia is desirable in patients with suspected intracranial disease, and this is because the hypocapnia can result in cerebral vasoconstriction. So if we suspect a patient has raised intracranial pressure as a result of, for example, head trauma or intracranial neoplasia, then mild amount of cerebral vasoconstriction can be useful to help minimize further increases in intracranial pressure. However, in most patients, hypocapnia is not desirable as it can result in cerebral ischemia. It's actually really hard to get a patient to be hypocapnic, and it's rarely achievable without mechanical or manual ventilation. Most anaesthetized patients, if they're breathing spontaneously, will not be hypocapnic. However, it's more common for anaesthetized patients, especially if they're spontaneously breathing, to be hypercapnic. Mild hypercapnia is often not regarded negatively, and in most patients it can actually have some beneficial side effects. Mild levels of hypercapnia can be sympathomimetic, resulting in slight increases in heart rate and slight increases in blood pressure. However, levels above 60 millimeters of mercury should be addressed, and this is usually through a change in ventilation, whether that is instigating manual ventilation or changing the ventilation parameters that are already set up. And this is because excessive levels of carbon dioxide can result in narcosis, reduced myocardial contractility, vasodilation, and metabolic acidosis. So when presented with a capnograph trace, sometimes it can be a little bit confusing as to where best to start. And I think the easiest place to start is to decide whether the patient is normocapnic, hypercapnic, or hypocapnic based upon the end-tidal carbon dioxide. From here, once we've decided whether the patient has an increased or decreased carbon dioxide level, we need to decide why. For this, we can go back to our first principles. So remember that carbon dioxide is produced in the body's cells as a result of metabolism, is carried to the lungs by circulation, and then removed by alveolar ventilation. We can then use these three different aspects to try and determine what may have changed in any of those aspects to result in either an increased or decreased end-tidal carbon dioxide. So we can see here the main reasons why a patient may be suffering from hypercapnia, or that is an increased end-tidal carbon dioxide. This is most commonly due to hypoventilation, which can occur due to a number of different reasons, including excessive anaesthetic depth, underlying patient disease such as cardiopulmonary, musculoskeletal and acid-base disorders, or patient factors including obesity, pregnancy and patient positioning. However, an increased end-tidal carbon dioxide level can also occur due to an increased production of carbon dioxide. So that is an increased metabolism. For example, a patient with fever or who's shivering. Or it can also occur as a result of an increase in the inspired concentration of carbon dioxide. That is with rebreathing, as we've already touched upon. In terms of a decreased end-tidal carbon dioxide or hypocapnia, we tend to split the reasons for this into those reasons which can result in a gradual decrease or those reasons which can result in a sudden or complete decrease. When regarding a gradual decrease, hyperventilation due to a light plane of anesthesia or because of a noxious stimuli is probably the most common. However, other encountered scenarios which are relatively common include a reduced carbon dioxide production, usually because of hypothermia, or as a result of hypotension, which can increase the alveolar dead space. Less common reasons can include conditions such as a pulmonary embolism, but that would also result in other concurrent signs, such as a reduced blood pressure and desaturation. We can also detect equipment problems with a decreased end-tidal carbon dioxide. We've already discussed detection of breathing systems leaks in the breathing system. That's a key example of some of the equipment problems we can find. And then when we're thinking about sudden or complete decreases of end-tidal carbon dioxide, which includes traces that can give us a flat line, we have to consider conditions such as equipment disconnection, so disconnection of the endotracheal tube from the breathing system, esophageal intubation, as we've already mentioned, or it could be something much more severe on the spectrum, including ventilation or circulation failure. So we do have to have that on our radar when we see a reduction in tidal carbon dioxide. So we've already discussed what the normal capnogram looks like. Here we've got an example of a slightly more prolonged trace. We've got 3 breaths here on this example. But what we're expecting is that each breath should look square or rectangular. We should see that all of the traces reach baseline, which is 0 millimeters of mercury during inspiration. We should have that nice rapid upstroke and downstroke, and our alveolar plateau may have a slight upward gradient. So that is normal, that we've already covered. Our next example is cardiac or cardiogenic oscillations. And this is a variant of normal. It's seen relatively commonly, but if we do see it, it's nothing really to worry about. So basically, what we see with cardiac oscillations is that our downstroke has a number of undulations. And if we had the patient in front of us, we would see that the undulations would match the patient's heart rate. And the theory behind this is that as the heart is beating, it's compressing the pulmonary tissue and moving some of the gas out of the lungs. We generally see this in barrel-chested patients, and in particularly when they have a low respiratory rate and when we're using low oxygen flows. So we can see here the real life example and the culprit that was responsible for this trace. You can see he's quite barrel chested, and you can see we have these nice undulations on the downstroke. And as I say, this is just a variant of normal, nothing to worry about if we see this. We've already talked quite a lot about hypercapnia. And obviously, we all know now the definition of hypercapnia is more than 45 millimeters of mercury. And usually when we have a hypercapnic trace, the trace appears normal. Simply there is the elevated end-tidal carbon dioxide. We've already talked in a reasonable amount of detail about the likely causes of hypercapnia. The most common reason is usually hypoventilation, which can occur for the reasons already discussed, including patient positioning, patient factors such as obesity or pregnancy, or increased anaesthetic depth. But another likely cause of hypercapnia is also increased carbon dioxide production, for example, if the patient is feverish. Again, just another real life example here. As we discussed previously, mild levels of hypercapnia are often not negative for the patient. So levels of up to sort of 50 to 55 millimeters of mercury are usually reasonably well tolerated unless the patient has intracranial disease, and can actually have some benefits. But when you're starting to get to levels such as that we can see in this picture here, sort of above 55 to 60 millimeters of mercury and tidal carbon dioxide, we probably need to be thinking about what we can do to alter that. And that is usually instigating a change in the patient's ventilation. Hypocapnia, again, we've discussed some of the reasons why we might have a patient who is experiencing hypocapnia. Usually we have a normal looking trace, but simply the end-tidal carbon dioxide is below the normal level of 35 millimeters of mercury. And again, this may occur due to reasons such as hyperventilation, decreased carbon dioxide production due to, for example, hypothermia, or due to increased alveolar dead space due to hypotension. Having said that, we often have a normal looking trace with hypocapnia. Sometimes, particularly with a patient who is hyperventilating, we can see traces that are not or don't have the very typical square waveform like we can see in this example here. So here we have a patient who is hyperventilating, and we seem to have lost some degree of the alveolar plateau. This patient is hypocapnic with an end-tidal CO2 of 28 millimeters of mercury, but this was due to hyperventilation. And we can see this combined with the patient's heart rate of 190 would seem to indicate that they're responding to some sort of noxious stimulus during anesthesia. We've already touched a little bit on rebreathing. So we've already said that rebreathing is basically when the patient is breathing back in some of their previously expired gas that contains carbon dioxide. What we usually see with rebreathing is that we have a relatively normal looking trace, apart from the fact that it is not reaching 0 millimeters of mercury, it doesn't reach baseline. We've already discussed some of the reasons why we can have a patient who is rebreathing. So with our non-rebreathing systems, such as T-piece, a Bain or parallel luck, then this is indicative of having too low of a fresh gas flow rate. Whereas if we're using a rebreathing system, then we may have depleted soda lime or faulty one-way valves, so we no longer have the unidirectional flow of gas. And we can see that in this picture here. So the rather fuzzy capnograph trace, apologies for the photo quality. I was trying to do about 3 different things at once at this point, but we can see that this patient is not only hypercapnic with an end-tidal carbon dioxide of 59 millimeters of mercury, we can see that the baseline is not reached. So we have an inspired carbon dioxide concentration of 10 millimeters of mercury. And the reason for this was that we had a malfunctioning inspiratory valve on our circle breathing system. And that was because somehow some of the soda lime or carbon dioxide absorber had got caught between the valve, so it could no longer close. So we no longer had the unidirectional flow of gas through the system, and it ended up with the patient rebreathing significantly. We can also use our capnograph trace to determine whether we have a patient who is either fighting the ventilator, sometimes known as bucking the ventilator, or the more correct term is patient-ventilator asynchrony. And what we can see here is that we will have periods of normal looking waveforms with occasional narrower or smaller breaths. Sometimes we can see small clefts in the plateau, the alveolar plateau of the trace. And what this means is that the patient is breathing either against or in between the ventilator breaths. Now, we can see in this example here on the picture on the left, we have some relatively normal looking capnograph traces, which are relatively square, giving an end-tidal carbon dioxide of 44 millimeters of mercury. And then we have the much smaller waveforms coming pretty much after every single ventilator breath. And this is the patient trying to breathe spontaneously in between the ventilator. Now we can see the ventilator settings at the bottom of the screen in the brown boxes. The number that says 200 is the patient's tidal volume in mils. So with a tidal volume of 200 mils, we can assume this patient was around about 20 kilos if we're using the caveat of 10 to 15 mils per kilo for a tidal volume. The next number along is the patient's respiratory rate. So this patient has a respiratory rate set to 12 breaths per minute. And this combination of the tidal volume and the respiratory rate is not adequate for this patient to try and stop them from fighting the ventilator. So the picture on the right was taken 5 minutes later and illustrates what has happened after I've made some changes to this patient's ventilation. So we can see that I've now increased the tidal volume to 230 mils. So I have given the patient a bigger breath, and I've increased the respiratory rate to 16. And the combination of increasing each breath and increasing the patient's respiratory rate, that overall increase in minute ventilation has stopped the patient's drive to breathe. They no longer are trying to fight the ventilator. And we can see this in our capnograph trace because we now have a nice, normal, even square waveforms. But also interestingly, we can see that the end-tidal carbon dioxide has not changed in either of these. So it's still reading at 44 millimeters of mercury. This example of what's often called a shark fin appearance to the trace indicates an increased expiratory resistance. And this is because if we look at the expiration, so the upstroke, it's taking an increased time for expiration. Now, this increased expiratory resistance means it's harder for the patient to breathe out, and this often occurs in situations such as bronchospasm. Examples being patients with asthma or who are undergoing an anaphylactic reaction. It can occur with a partial obstruction or kinking of the endotracheal tube, but it can also be an artifact in patients who have a low tidal volume when we're using a side stream analyzer that has a long response time. We can see here, I had an example of a cat who was showing that very stereotypical shark's fin type appearance to the capnograph trace. So this is taking a long time for the patient to expire. They're finding it quite hard. There's a lot of resistance for them to expire. And this was because they had a mucus plug in the end of the endotracheal tube that we can see here. This is also resulting in the patients hypoventilating slightly with an end-tidal carbon dioxide of 47 millimeters of mercury, and they also had desaturated slightly with a pulse oximeter reading of 89%. So this is an important trace to appreciate, and if we see this trace, then we need to do a bit of troubleshooting to try and find out what's going on, because it could indicate that, as I say, in this instance, we had a partial obstruction of the tube, but it could also indicate that the patient is suffering some degree of bronchoconstriction. In this case, thankfully, once we extubated and reintubated with a new tube, everything returned to normal. Now, this is an example of a gradual decrease in the amplitude of the trace. And this can represent a sliding scale of things from relatively minor to some quite severe scenarios. So on the relatively minor side of things, a gradual decrease over time can increase or can represent an increased minute ventilation of the patient. But obviously, if this is the cause of this decrease in amplitude of the trace over time, then there must have been a change in the patient's respiratory rate or effort, or a change in the manual or mechanical ventilation in order to see this change in minute ventilation. This trace might also indicate a leak of gas from the system. Again, this could be a leak in your endotracheal tube cuff. So that's something that would need to be investigated. But at the more severe end of the scale, this sort of trace might represent a decreased delivery of venous blood back to the heart, and therefore it might be an impending cardiac arrest. So if we see something like this, the key is not to panic, to troubleshoot things that are that might be happening, but also have in the back of our minds that it might be the first indicator that something more serious is going on. Now, in this video, this is a video of a horse, so don't be alarmed at the low heart rate. That was normal for this horse. But this horse is about to be euthanized. We can see here that the horse has gone into ventricular fibrillation. It's a very good example of what happens on an ECG with ventricular fibrillation. But watch what happens with the patient's capnograph trace. This patient is being mechanically ventilated throughout the euthanasia. The euthanasia of this horse is obviously under anaesthesia, but we can see that the capnograph trace is decreasing over time, because as there is decreased circulation, that the patient has gone into a cardiac arrest, there is a decrease in the amplitude of the trace of our capnograph. Now, in this particular instance, the ventricular fibrillation occurred very quickly, and that was our first indication that something was not altogether normal. But occasionally, it can be that the changes that we're seeing on the capnograph trace happen first, and they are our first indicator that something is going wrong. We do sometimes come across traces where we have a sudden flat line on the capnograph. Now, if we've had a normal looking trace prior to the flat line, the most likely cause is that the patient has become disconnected from the breathing system and therefore disconnected from the capnograph sensor. It's also possible that the machine is calibrating and therefore just needs a minute to reevaluate things, and then it'll start giving you a normal trace again. If you're in the situation that there's never been a capnogram trace from the start of anaesthesia, then it's highly likely that the endotracheal tube has been placed in the esophagus rather than the trachea. However, such a trace could also indicate other patient factors, for example, apnea or respiratory arrest, or it could also indicate a sudden cardiac arrest. So again, it's just something, if we see a sudden flat line on our capnograph trace, we need to just start troubleshooting and evaluating the patient and trying to figure out what's going on. And then finally, we've already briefly touched on this, is what we might see if we have a system leak. And this example is almost pathognomonic for a system leak. What we tend to see is a shallow expiratory upstroke, a low end-tidal carbon dioxide, and a short alveolar plateau. And personally, I tend to call these short and peaky waves. And this is most commonly occurs as a result of an inadequate seal due to usually a poorly inflated or a damaged endotracheal tube cuff, or if we have an endotracheal tube which is too small, or we're simply using an uncuffed endotracheal tube or an uncuffed tracheostomy tube. But this, if we see that we have normal capnogram traces at the start of anaesthesia and then over time we end up with this change in morphology, it's worthwhile checking the endotracheal tube cuff. So to conclude, as with any piece of monitoring equipment, knowledge of the basic physiological principles will hopefully allow us easier interpretation of our capnography. Capnography is a very useful piece of monitoring equipment in clinical practice, and it can provide us with information on both the patient and the equipment that we're using. And then also capnography can contribute to oxygen and volatile agent conservation, which can be important in order to help us minimize our economic impacts, our environmental impacts, and also help us conserve our resources. We should be hosting a question and answer session with one of the members of the anaesthesia team, particularly on capnography, but also on any aspect of anaesthesia on Thursday, the 16th of April. So if you have an interest in joining in with this question and answer session, then please don't hesitate to email Davies CPD and we can get you registered up for this. Thank you for listening.